Feel free to ask questions as we're going through all this. I mean, basically what I want to talk about today is really going over what the different types of gluten-related disorders in addition to celiac there are, and really being able to recognize that and manage that. And then also reviewing the screening and referral patterns of pediatricians in the potential diagnosis of celiac disease. My interest is in medical education, so teaching not only medical students, but general pediatricians and PGI docs about what our guidelines are and what our screening practices are, whether that falls in line with our guidelines. And so I'll be reviewing that. I mean, what's been happening over the last 5 or 10 years is we've had an increased awareness of gluten-related disorders. However, how many people really need to be on a gluten-free diet versus how many people really have a diagnosis or just are on it for other reasons has become a little bit overwhelming, and I'll get into that. And a lot of it is really due to a media presence and a celebrity influence. A lot of stars will write books saying how gluten has really changed their lives, and because of that, this gets into the general lay media, and patients will come to us and on a gluten-free diet for different types of ailments that may not have been previously evaluated for celiac disease. And in addition, what we're seeing more recently is an increase in the availability of gluten-free foods, which is helpful for our patients with celiac, but also is a big pressure that whether this gluten-free means healthy, and I'll talk more about that. So when is a gluten-free diet medically needed? So there's 3 classes of gluten-related disorders. So medically necessary would fall under those that are immune-mediated, and that would be celiac disease, which occurs in about 1% of the population. And that would also be a wheat allergy, which occurs in about 0.1% of the population. These 2 diseases are something that we can measure by checking biomarkers, so there are serology and other testing available for these diseases, and we'll talk more about that. And then there's the not medically necessary, and I think the reason I put that under that is this is a non-immune mediated, is this blanket diagnosis of non-celiac gluten sensitivity. And the incidence for that is low or up to 8% in adults, but up to 5%, 6% in pediatrics. However, there are some physicians who don't even believe this even exists and wonder whether this is really either a wheat intolerance or really not a diagnosis at all. And so we'll talk a little bit about that. And I think one of the problems with this disease is that there's no biomarkers available, although I'll talk about testing that some people do and we'll question whether or not that's really indicated. So with celiac disease, what happens is, I don't know if you probably can all hear me, but what happens is you have wheat, rye, barley, and gluten grain that is broken down to small intestines, and then once it gets passed into the enterocyte, that's when an immune reaction will start. And so that's when you will get increase in some serologic markers. You'll have activation of T cells through IL-15 and IL-21, leading to damage of the villi, increased intraepithelial lymphocytes that we'll see, as well as villus atrophy that we note. So this is an immune-mediated response. You need to have genetic predisposition, so up to 35 to 40% of the population are at risk for developing celiac. And then it presents in 3 different ways: the GI classic way, the non-GI symptoms or the atypical, and then the asymptomatic group, which is usually the high-risk groups. And we'll briefly go over that. So in typical manifestations, these are your young infants, 6 months to 24 months of life, who present with vomiting, constipation, diarrhea. They may also present with failure to thrive, although right now about 1/3 of patients may be overweight or obese at the time of diagnosis. And it could lead to weight loss, anorexia, abdominal pain, and there's a thought that intussusception is increased in children with celiac disease due to the intestinal inflammation acting as a lead point. So this is for the younger group. Then you have the atypical. And the atypical includes those with short stature, so we get referrals from endocrinologists, those with dental enamel defects, where you'll see pitting and grooves in the teeth with loss of enamel. And this usually is in the secondary dentition We will often get referrals from dentists who feel that things don't make sense, whether it's reflux related, whether it's celiac related, and it may be the only presenting sign for celiac disease, and it will improve on the gluten-free diet. Headaches, arthritis, can be seen, osteopenia, osteoporosis due to poor calcium absorption. Iron deficiency anemia is the most common presentation in adults for celiac disease. So these are children or adults who are iron deficient. You supplement with iron for 3 months, but you don't notice an improvement in their iron levels or their anemia, and then you want to think about celiac disease. Hepatitis, so often children will have an elevation of their AST, ALT, so kids presenting to our fatty liver clinic, because of the elevation, sometimes they're usually more on the normal weight side than they are on the obese side that you would see in typical NAFLD. And dermatitis herpetiformis. So there's a lot of data out there saying different rashes may go away on a gluten-free diet. The only one that's really documented, that's real, is DH. And this is more seen in adults. I've seen it in a couple of teenagers, and they could be macules, papules, or vesicles. It's very itchy. You can see that it's symmetric. 90% of patients won't have GI symptoms, but the majority will have villus atrophy, and they are gluten sensitive. So taking away gluten will cause an improvement of the rash. Other potential associations, so kids will sometimes say that, or parents will say that kids' moods get better, fatigue, some people, there might be female infertility, and then some neurologic issues, especially with some vitamin deficiencies. These are still associations that have to be better worked out because it's really hard to know whether it's truly related to gluten. And then the last group, so typical, atypical, and then the asymptomatic group. And so the asymptomatic group are the high-risk groups that you screen because they are high risk. And so we say 1% of the population, about 1 in 133, have celiac disease. If you have a first-degree relative, that number goes down in 1 in 20. At a secondary relative, about 1 in 30. And so your chance increases. I always tell families, though, it's still a 95% chance that family members don't have it. So it's still, even though increased in the general population, still a high likelihood that not everyone in the family has it. Type 1 diabetics, typically this is seen in about 5 to 10% of celiac will have celiac disease if they have type 1 diabetes. They're typically screened on an annual basis. One of the caveats with type 1 diabetics is that if you screen at the time of diagnosis, you can have a falsely elevated serology at the time of diagnosis, so you want to sort of wait until the blood sugars are better under control to see if the elevation of the serologic markers are due to the uncontrolled diabetes or truly due to possible celiac disease. And other high-risk groups include Down syndrome, Williams and Turner, and selective IgA deficiency. What's changed for celiac and why it's become so much more thought about is because our serologic testing markers have improved. So in the 80s, really all we had was the anti-GLE antibody. And in the late 80s, that's when the endomysial antibody was discovered and utilized. And that's a very specific test. And in the late 90s is when the TTG was developed. And TTG has become our standard screening serologic marker. The AGA, although, and we'll talk about this in a survey that we did, the AGA really is an obsolete antibody. It's been replaced by the deaminated gluten, which is a new second-generation gluten, which is more specific for celiac disease. But it's still being used a little bit, especially in certain laboratories, and we'll talk about that. The recommendations of NASPGHAN, which is our North American Society of PGI, as well as SPGHAN, says that screening should include a total IgA to make sure the child is not IgA deficient, and then a tissue transglutaminase IgA to make sure to see if that's elevated. If that's elevated, that's when further testing should be indicated. What's unique for pediatrics is that children under 2 may have a normal TTG IgA, so the thought is we may need to check the deaminated gluten IgA as a marker to help us figure out whether this could be celiac disease. And there is a potential role for some genetic markers. However, the utility of genetic markers has not really been studied. If you're IgA deficient, you want, instead of checking the IgA version of these antibodies, we need to check the IgG version. And also for those kids, genetic markers may also be helpful. And the reason for that is that the IgA deficient kids, the IgG markers are they're non-specific, so they can be falsely elevated or just low, and it's hard to know whether they predict. So sometimes with this specific group, you may end up doing an endoscopy if the level of suspicion is high. So we did a survey to look to see what serologic tests were available. We identified 25 different hospitals and laboratories in the state of Connecticut. We contacted and received data from 23 of them, and majority of labs offered celiac panels, and there were 16 unique panels available. And more than half of these panels included an anti-gluten IgA, and another half included endomysial antibodies. So these are tests that are not necessarily necessary in the screening, but maybe being checked off by practitioners, and it can lead to unnecessary further testing. So if you have anti-gluten that's elevated, sometimes parents may go on a gluten-free diet without really confirming the diagnosis, or it may lead to referrals and other testing because of that. People worry about that test. And about 1/3 of panels included the deaminated gluten, again, which is really only useful in those under 2 years of age. We still need to do further study to assess the physician's use of these panels, whether they're ordering them independently or they're ordering them in the use of panels, but we do see that a lot more tests may be being done than are really needed. Now, as I was alluding to before, why it's important to have a specialist look and evaluate is that a TTG that's elevated doesn't always mean celiac disease. And it can be elevated in liver disease, in autoimmune conditions like we spoke about for type 1 diabetes, Crohn's disease, in neoplastic tumors, as well as viral infections. And it's not uncommon for celiac markers to be checked after a child has a GI bug because of persistent vomiting or persistent belly pain, and it's not uncommon to have that TTG be a 5 or a 6 when normal is under 3, and that normalizes once the viral infection goes away. And I've had children come to me on a gluten-free diet with a diagnosis of celiac disease based on those very mild elevations, and that's just something I think education is going to be really important. So we looked at the community pediatrician's approach to children with celiac disease, surveying community docs across Connecticut. 83% of them were in practice for more than 10 years. And then we looked at 3 different criteria: screening, management, and referral for potential celiac disease. So the majority of pediatricians would correctly screen using the TTG-IgA, about 93%, but other serology were frequently checked as well. So they are checking more than is necessarily needed. In terms of management, about 25% recommend a gluten-free diet at least most of the time prior to a GI referral, and about 2/3 make the diagnosis of celiac based on serology at least some of the time. But they do refer about over 90% of the time to GI. And so what's concerning here is the management. With having 25% of patients with abnormal serology really needs to be evaluated by a specialist. Starting a gluten-free diet, although considered healthy, we'll talk about, it may not always have all the nutrients that you need, and it may be actually higher in certain other nutrients and lower in others. And to make the diagnosis based on serology really isn't the gold standard right now, and even if in some guidelines you say you can skip the biopsy, there are certain criteria that need to be met for that. So what happens if a child is already on a gluten-free diet? We try to encourage parents to put them back on gluten. If they are hesitant, this is where the genetic markers can be helpful. So if they're part of that 60% of the population that doesn't have the gene, then you know this is not celiac disease. If they do, you can then at that point have them reintroduce gluten. The current ACG recommendations is that if you introduce gluten for at least 2 weeks, there should be some intestinal changes that you would detect on biopsy. If they're able to deal with gluten back in the diet for up to 6 weeks, you can then check serology. If they're elevated, then proceed with the endoscopy to confirm the diagnosis. If everything looks still normal, then you can wait up to 12 weeks. So even just being on the diet for 6 weeks, you can go back on the gluten-free diet, you'll have a peak in that TTG, usually after 12 weeks later. So this is a good way, and this is what happens, I would say, about 30% of the time patients come into the office where you have to restart gluten. And just making sure that you can really determine whether or not this is truly a medically indicated reason to be on a gluten-free diet. And then to biopsy or not to biopsy. So the ESPGHAN guidelines really say that these are guidelines to skip the biopsy, that if there's a GI typical symptomatic, so someone with failure to thrive, poor weight gain, vomiting, diarrhea, constipation, who has a tissue transglutaminase more than 10 times the upper limit of normal, the endomysial antibody is positive, and that positive is also something that needs to be looked at closely, because what happens with positive is that this test is by dilution, so you'll get a ratio. And so a 1 drop of blood diluted in 1 drop of water is a 1-to-1. Then you go 1-to-2, 1-to-4, 1-to-8. Anything more than 1-to-40 dilution, it's still positive, is considered a true positive. Anything less should be really looked at with more scrutiny. And then a biopsy would be indicated in any asymptomatic or atypical presentation. And the recommendation is at least 5 biopsies in the duodenum with at least 1 duodenal bulb biopsy. These guidelines are still very controversial in the United States. Majority of gastroenterologists are still recommending a biopsy to confirm the diagnosis. There has been one study looking to see retrospectively whether if we follow these guidelines, whether we would catch everyone with celiac disease. So these are people who had biopsies. You look back to see what their markers were. Did they meet these criteria of endomysial antibody being positive, tissue transglutaminase greater than 10 times the upper limit of normal? With these criteria, if you skip biopsy, everyone there, 100% would have celiac disease, but you can see here about 12% would have other diagnoses. And that would include H. pylori, that would include EOE, or peptic ulcer disease. And so what I typically use this data for is to tell parents, if we're skipping the biopsy, there is still a chance that your child's belly pain or other symptoms can be related to other diseases. And so it was more useful to figure out from the beginning of what we're treating. And if it is celiac, it could also be EOE, or it could be H. pylori that we can address at day 1 versus waiting 6 months or a year to sort of figure that out. If they elect not to do the biopsy, we would then just possibly scope depending on what the symptoms look like in 6 months or a year from now. In terms of healthcare maintenance, this is also an uncharted territory. So if you look at the guidelines from ESPGHAN and NASPGHAN, it basically says follow them to make sure there's improvement. There's no real guidelines. ACG guidelines actually say monitor TTG-IgA for at least every 3 to 6 months until they normalize, and they usually normalize at a year or a year and a half, and then annually to make sure they're still adherent to the diet. There are certain blood tests that we think about doing. Because of the increased association with autoimmune disorders, we do try to check thyroid functions on a somewhat regular basis. We used to think about a lot of vitamin deficiencies that can develop, but usually there was a recent study, which is for the fat-soluble vitamins, that showed that the only people who screening didn't help. Usually people presented with symptoms prior to you effectively finding someone asymptomatic who had a deficiency. We do check the hepatitis B serology because kids with celiac have a lower chance of conversion with hepatitis B. So after the primary series, which they usually get in the United States during the first year of life, we would check to see if they have the surface antibody. And if they are negative, we would give them 1 booster shot, a month later check that they responded, and then document whether or not they responded. So we looked at management practices now of pediatric gastroenterologists. We had 240 responders. About half were in practice for more than 10 years, and it was a variety, but the majority were in academic practice. 35% diagnosed based on serology alone, even if it didn't meet the ESPGHAN criteria, and primarily the number 1 reason for that was parental concern about undergoing an endoscopy. 75% took at least 5 biopsies, which again is that criteria. For children less than 2, 90% checked a TTG-IgA, about half checked the GGP-IgA, and whether or not that is an added effort or not, but that's somewhat recommended. Follow-up practices are not uniform. Some would refer back to the pediatrician once they normalize, some refer back to the pediatrician once they've established a diagnosis. Right now, the treatment, again, is just a gluten-free diet. You can limit lactose for a year because they may lose lactase on the brush border initially because of the villi blunting. And they can eat oats. They should be gluten-free oats, but in limited amounts, so usually 1 serving a day, about 50 grams. What's interesting, sort of what we were talking about before, more people are talking about gluten-free diet. And if you look at a recent study that was published last month, if you look at the x-axis is really from 2005 to 2015, the interest over or Google searches of celiac has remained pretty much constant over the last 10 years, while that for gluten-free has rapidly increased. And so if we think about what we had in that first slide, medically indicated, so 1% of the population has celiac, 0.1% has wheat allergy. So that's 1.1% of people that should be following a gluten-free diet. It's about 1 in 5 in the United States, so 20% of people in the United States follow the gluten-free diet. About 33% of millennials follow the gluten-free diet. It's equal in males and females. More non-whites than whites are following the gluten-free diet. And there's no difference based on socioeconomic status. It's still 1 in 5, even in households making less than $30,000. So that comes into play because there is some inherent selling point for the gluten-free diet. And when it is more expensive to be on a gluten-free diet, so you really want to make sure that we're educating families on why they're doing it. The reasons for it, no reason for about a third. It's healthier, according to about a quarter, and 13% are doing it for weight loss. But is the gluten-free diet healthy? It can be low in fiber, iron, the B vitamins. It can be low in calcium and phosphorus. It can be low in zinc. So there is a risk for iron deficiency anemia, reduced bone mineralization, constipation, and there is a reliance on the rice grain. And in April of this year, the FDA wrote basically a concern, as traditionally in the United States, we would ask children when we were starting infant feeding to start solids with rice cereal. And the thought is, by body weight, 8-month-olds are actually eating the most rice by body weight of all the age groups. But there's also a concern for those with celiac disease. Most of the gluten-free products and alternatives, especially the processed foods, are rice-based. And so that's something that we need to make sure that they're following a dietitian to make sure they're getting a good variety of foods. Processed gluten-free foods, there's no real criteria to fortify them like it is with our breads. And weight gain can be a risk factor. And with 1/3 being overweight, at least overweight at diagnosis, this is of great concern. So just briefly at this chart, gluten-free versus gluten-containing foods. Those in red means that it's worse for you, and the green means that gluten-free foods are better. So if you look at it, they're much higher in gluten-free foods compared to their equivalent of gluten-containing foods, higher in salt, lower in fiber, lower in protein, higher in saturated fat. And so about 1/3 less protein in the equivalent of gluten-free products versus the gluten-containing, and about 2 times more fat, specifically saturated fat in gluten-free products. But, we do have a percentage of the population that needs a gluten-free diet, and it can be a well-balanced diet, and it requires careful planning, experimenting with new grains, amaranth, millet, buckwheat, teff, that are high in B vitamins, iron, and fiber. Most will require a multivitamin in the beginning, but then that can be weaned off, usually once the TTG normalizes. And to eat naturally gluten-free products versus a lot of the processed foods, because that's where the extra fat is usually added to make things taste better. I put down the Fasano diet. Typically, Dr. Fasano from MGH, what he recommends if you're having difficulty with a child's numbers in terms of the TTG normalizing, is to say your diet now is just veggies, fruits, meats, and fish, and see if that normalizes it. Because what happens is, when it doesn't normalize, it makes you think, is there another diagnosis, or is there a non-compliance or non-adherence to the diet? And this just sort of simplifies, do this for 6 months, let's see if the TTG goes down. And working with a dietitian, again, can't be emphasized. So quality of life on a gluten-free diet. Cost is a big thing, and especially with our children with type 1 diabetes, they're not only trying to get a diabetic diet, but also follow a gluten-free diet, which can be very complicated. Availability has gotten a lot better in terms of there are a lot more gluten-free products out there, but it still can be difficult in certain scenarios. Taste, again, is a big issue, but with good resources like support groups that can help you figure out where to find good alternatives, and moms and dads are sharing recipes of things they've tried and experimented with at home. Social isolation is very, kids when they go to camp have to eat different foods or have to bring their own food instead of sort of socializing at lunch or with their friends when they go out after sports or things like that. That can be challenging. School lunches. So kids with celiac disease in the United States fall under the 504B plan. So there's a chronic disorder. So the schools are obligated to give them some options. And every school does it differently. This is more public schools. Private schools really can avoid that or not really follow it as clearly and basically say, bring your own lunch. But everyone does it differently. One is giving salad as the option. One is actually giving a variety of foods as an option, and parents really need to work with the school system to make that possible. And then eating out is always a challenge, and so eating out, asking questions that is, do you have 2 fryers? So having French fries can be normal, but if you're mixing it with something with breaded chicken or something like that, it's completely cross-contamination. What's helpful slightly is that previous to 2014, it was just the 8 most common allergens that were labeled on processed foods, and that included wheat, but not gluten. And so that became a lot easier in 2014 when the FDA issued a rule of what gluten-free is. It's less than 20 parts per million of gluten in a food product, and it regulates all packaged foods. So packaged foods that say gluten-free should be following this rule as of 2014. And potential cross-contamination is what makes things very, very challenging. So candy, communion wafers, matzah, drink mixes, soy sauce, asking restaurants for gluten-free soy sauce, which most do carry or will remove soy sauce. I've had a child who was doing well when she was diagnosed at 6 or 7 years of life and then started having increased TTG after 12 or 13 years of life, and the family was really in shock about what was going on, and it turned out she had switched her makeup and was licking her lipstick, which was gluten containing, and her TTG was going higher. So all these different things that need to be taken into account. If you have younger children with celiac, Play-Doh in the daycares are going to be a problem, and there is a great, easy, wheat-free recipe that you can make, but it has to be education of the daycare providers and also willingness of the daycare providers. Fast food is difficult. If you're making a sandwich in a deli and you mix very easily, 1/200th of a piece of bread is enough to cause issues. And sandwich shops, pizza. So it's all these different things. A lot of the great things is that there's a lot of options at restaurants, gluten-free pasta, gluten-free pizza, but if it's made in the same oven as where the regular pizza is, it's going to be cross-contaminated. There are a lot of other non-dietary therapies that are out there. There's stage 3 in adults right now where people who are still having some issues with a mildly elevated TTG you can take a pill that helps break down the gluten fragments, so decreasing the immune response. We'll see how effective this is. The ones that you see on the market now, if you go into your local pharmacy, are not actually effective. And there are some IL-15 inhibitors to help decrease that are being studied. They're doing a study up in Chicago of whether Singulair and Montelukast actually can also help. But most of these are adults for now, and also most of these studies are as an adjunct. So it's not replacing the gluten-free diet, it's sort of like helping with any of that mild cross-contamination. And so really, with all of these things, it's important to have, we at Yale have a celiac program where we work with our community allergists to make sure it's not a wheat allergy. We work with our endocrinologists to sort of help come up with a dietary plan for our diabetics. We have a dietitian who solely works with us for a gluten-free diet. And we work with social work and psych to help the families figure things out in the school system if there's any obstacles. I want to end with a case presentation just to talk about what an evaluation would entail and why it's important to go through these steps. So EP is a 1-year-old girl who presents with poor weight gain since 6 months of life, was described as a picky eater, 4 bowel movements per day. Her weight at 6 months was at the 37th percentile, and at 10 months of life dropped to the 17th, and by 1 year on day of presentation was at the 5th. There was a family history of thyroid disease, and mom said possible celiac disease. Someone in her grandmother was on a gluten-free diet, but never tested. We decided just to try to increase the calories in her diet. I checked some labs, and you can see at this time, this is a couple years ago, we checked the total IgA, the tissue transglutaminase IgA, and it was the old anti-GLA antibody, again, which should never be checked, which was mildly elevated. Normal is less than 20, but all the other markers were negative. At 1 month follow-up, we went over the results. She had good weight gain by trying to increase her calories, but she was developing vomiting and looser stools. Due to the fact of this questionable history of celiac disease, as well as this non-specific marker that was elevated, mom decided to put her on a gluten-free diet. And you can see the first arrow is when gluten was introduced at 6 months of life. From that point on, the weight went down. Mom removed the gluten, and then the weight went up. We decided to do an upper endoscopy to see whether or not this was truly celiac disease or not. And we put her back on gluten. She developed diarrhea. 6 weeks later, we did the endoscopy, and it was completely normal and negative for celiac. And at that point, just to make sure that there was no sampling error, we did the genetic markers, which were both negative. So this is definitely not celiac disease. So what is non-celiac gluten sensitivity? It's basically the similar symptoms as you would see in wheat allergy or with celiac disease, but everything is normal. Serology is normal, allergy test to wheat is normal, and there's no intestinal damage. There are a lot of expensive tests out there for sensitivities, and they can cost up to $2,500, and they're not covered by insurance, and rightly so, because they're not accurate. A lot of families would get what's called IgG testing, and so when you think about allergy testing, and allergy testing is to IgE, right? And IgE shows you whether or not there's at least sensitization to a certain food. And IgG testing just shows exposure. And so in the state of New York, they actually now won't run these tests because they realize how inaccurate they are. And so it's very common for families to come to our office with these testing done and have eliminated many, many food products, including gluten. And then wheat allergy, again, is the same thing, except it usually happens and very common the first year of life and then decreases as kids get older. And the symptoms can be abdominal pain, nausea, vomiting, diarrhea. The way we diagnose wheat allergy is with skin prick tests, IgE serology, or do an oral wheat challenge by doing a double-blind placebo-controlled. So giving a child 2 different things and see what the reactions are. Or some thoughts about doing patch testing since there may not be an immediate response. And these are just used as a guide because having these tests positive doesn't mean there's actually a reaction that's going on. So we did the wheat IgE, which was negative, continued to grow well on a gluten-free diet. I then referred to an allergist who did patch testing that was severely positive. And so because that was positive, I was thinking maybe this is wheat intolerance. And we tried to introduce the other gluten-containing grains like rye and barley, and that did not help. And so we put her back on a gluten-free diet. Every 6 months to a year, we're retesting the patch and also trying to reintroduce the food into her diet with the hope that by the time she's 5 or 6, this will be outgrown. So celiac disease and gluten-related disorders are being diagnosed with more frequency. Though awareness has increased, some of that awareness is not the most evidence-based, and so really public education is needed to expel the myth that a gluten-free diet is always healthy. Pilot studies that we've done demonstrate that further education on the management of celiac disease is needed among community pediatricians and as well as us as well. And further research should focus on developing effective education modules to help address these gaps and limit the amount of children who may be started falsely or unnecessarily on a gluten-free diet. Great, that's it.